Hello, everybody. Greetings from the country of Lithuania. During recent years, I had an opportunity and chance to communicate with the clinicians from different institutions and societies in Ukraine. Just to start, my name is Julius Пташекас, and it so turned that more than 35 years I'm working with the different issues and problems related to the disorders and the treatments of those disorders in the field of coagulation and thrombosis, bleeding risk control, antithrombotics, different situations with critical patients, all kinds of issues that we also had an opportunity to discuss with the professionals from Ukraine. I have to say outstanding professionals from Ukraine. Recently, I have been a lot working with my university in Riga, and there was complicated patient with Lenier's syndrome, with the thrombosis of jugular vein, and they just recollected that we have same serious situations with the patients in Ukrainian hospitals. And the management of persistent thrombosis always is a challenge and issue. And persistent thrombosis, sometimes followed by persistent risk situation, and risk control is required, especially in the area of transplantations. Liver transplantation is the field where both thrombosis and bleeding are extremely important to manage properly. I have to say that my communication with the Шалімова Institute of Transplantology is an example of the progress that can be made in this field. Шалімова Institute introduced for bleeding risk control, for liver reserve identification, prothrombin time test, which is based on the modern technology, additional knowledge and maybe additional algorithm to use it in routine clinical practice. And I would like to congratulate Шалімова Institute professionals who successfully use this Ovrin PT test for their own patients' clinical needs. Management of thrombosis is based on two vectors. One vector is evaluation if our anti-thrombotic treatment, anticoagulation, is efficient in terms of thrombosis regression. So currently we have technology, we have opportunity to monitor early prethrombotic marker soluble fibrin-mономер test, which allows us to measure how thrombogenesis is activated and how thromboprocessing is also facilitated to see if anticoagulation is efficient. It's early prethrombotic marker test, which allows us as well to monitor recurrency of thrombosis, which we treat now with our antithrombotic treatment. At the same time, we have to see how thrombosis is going for regression, is really diminishing. If it is diminishing, this we can monitor with the high specificity. High specificity is a critical issue to get correct answer from the laboratory of Д-димер test. Both Шалімова Institute, also other institutions in Ukraine, working on that. How to implement high specificity Д-димер test to have most efficient monitoring if antithrombotic treatment is helping us to reduce thrombosis. If we don't see the progress both in early pre-thrombotic fibrin-mономер test and post-thrombotic high-specificity Д-димер test, it means that our strategy is not working. So we come to a next vector, to a second vector in thrombosis management, to see if our anticoagulation is efficient enough in terms of effect on hemostasis. If we have heparinization, both old heparin and new heparin, I mean the low molecular weight heparin, we have an opportunity to measure specifically anti-10A activity with anti-10A test, which has an interval showing us if this anticoagulation is in correct interval towards effect on hemostasis. If it is between 0.3 and 0.7 international units on milliliter of plasma, it means that we have efficient work of heparinization. Question is if this is enough to reduce concentrations of high specific D-dimer, thromboproduction, and amounts of soluble fibrin-monomers, which says activation, thrombotic activation, and sometimes it's efficient, sometimes not. So if we have right concentration of anticoagulant, right effect of anticoagulant, it means that we have to look for increase of our strategy to achieve reduction of the dimer, to achieve reduction of fibrin monomers. If this is not working, we switch to another type of anticoagulation, maybe using along to that antiplatelet drugs. But we have to achieve reduction and stabilization of thromboproduction by high specific dimer test and thrombotic activation by reduction of concentration of fibrin monomers. If we have novel anticoagulants, rivaroxaban, dabigatran, so we have for rivaroxaban, same anti-10A test showing us concentration of rivaroxaban. Therapeutic concentration is between 100 and 140 nanograms per milliliter. If we have this concentration, but the dimer is not reducing and fibrin monomer is not coming down, it means this concentration is not sufficient to get clinical therapeutical effect. So management of thrombosis using thrombogenesis testing, thromboproduction testing with the dimer and fibrin monomers, and evaluating effect on hemostasis of anticoagulant by anti-10A test, measuring concentration of rivaroxaban or effect of heparinization, and heparin test measuring concentration of dabigatran type anticoagulants allows us in a modern way to have management algorithm of thrombosis using current practices. How this to implement? Clearly, technology is behind. Biomarker medicine is behind. So my experience and cooperation, long years with Stago platform allows that to do. And when I advise and consult, clearly I'm responsible that institution or hospital will have this opportunity available. This is not my mission to provide, but my mission is to help to understand the most efficient way to proceed forward. So thank you very much for your attention. I wish everybody success in management of thrombosis with current tools and algorithms. Thank you very much.